Sodium is the major cation in the extracellular fluid and plays a significant role in fluid balance and regulation of fluid volume. Sodium balance is regulated primarily by aldosterone and antidiuretic hormone, and sodium movement into and out of the cells via active transport across the cellular membrane. Sodium is obtained through the diet, is absorbed continuously by the intestines, and is excreted by the kidneys via the urine. When combined with chloride, the resulting substance is table salt. Sodium is found in most body secretions and performs the functions listed on this slide. The recommended daily intake of sodium is no more than 2.3 grams per day. The amount contained in slightly more than 1 teaspoon of table salt. Most Americans consume 4 to 6 grams of salt per day, which contributes to the development of hypertension and heart disease. Sodium is often hidden in processed foods, canned foods, seasonings, and medications such as antacids, cough syrups, and cold remedies. Sodium imbalance occurs when there is a decrease or increase in the sodium content of the blood to the amount of water in the body. Hyponatremia is the most common electrolyte imbalance in the United States. Onset may be sudden or gradual, but a sudden onset is more dangerous for patients. Manifestations are usually not apparent until serum sodium levels decrease to less than 120 milliequivalents per liter. A decrease in serum sodium causes water to move out of the ECF and into the ICF, resulting in cellular edema, which reduces cell function and transmission of impulses. Hypernatremia, or sodium excess, is a serum sodium level greater than 145 milliequivalents per liter. Hypernatremia is most common in older adults who may have a decreased thirst sensation or may be unable to access fluids independently. Onset may be sudden or gradual, but a sudden onset is more dangerous for the patients. An increase in serum sodium causes water to move out of the ICF and into the ECF, resulting in cellular dehydration and stimulation or overstimulation of excitable cells. Sodium has a profound effect on fluid balance in the body because, as a general rule, wherever sodium goes, water follows. Thus, the shifting of water into and out of cells depends primarily on sodium concentration of the blood and other extracellular fluids. Under normal circumstances, the osmolalities of ECF and ICF are about equal, or isotonic, even though these fluids are composed of different solutes. However, a higher than normal hypertonic concentration of sodium in ECF causes water to move out of cells via osmosis to equalize the sodium concentration between the ECF and the ICF. Conversely, a lower than normal hypotonic concentration of sodium in the ECF causes water to shift into the cells to reestablish the sodium balance between the ICF and the ECF. The plasma osmolality of blood, normally 275 to 295 milliosmoles per kilogram, can be roughly estimated by doubling the serum sodium laboratory value, normally 135 to 145 milliequivalents per liter if the plasma osmolality is elevated. This means that the solutes, mainly sodium, in the blood are concentrated and that the water is moving out of the cells, placing the patient at risk for cellular dehydration and other electrolyte imbalances. There are three types of both hyponatremia and hypernatremia: euvolemic, hypovolemic, and hypervolemic. These terms describe the relationship between a patient's fluid status and serum sodium level. The specific sodium imbalance depends on how much the sodium content decreases or increases in proportion to total body water. Euvolemic sodium imbalance occurs when the amount of water in the body is normal or near normal. Euvolemic hyponatremia is a decrease in sodium that occurs when the amount of water in the body is normal or near normal. Euvolemic hypernatremia is an increase in serum sodium occurs when the amount of water in the body is normal or near normal. Hypovolemic sodium imbalances occurs when the amount of water in the body is decreased, or fluid volume deficit. Hypovolemic hyponatremia occurs when there is not enough water and not enough sodium in the bloodstream. Hypovolemic hypernatremia occurs when there is not enough water in the bloodstream. The lack of water concentrates the normal sodium content in the body, increasing the sodium level in the blood. Hypervolemic sodium imbalances occur when the amount of water in the body is increased, or fluid volume excess. Hypervolemic hyponatremia occurs when there is too much water in the bloodstream. The excessive water dilutes the normal sodium content in the body, lowering the serum sodium level of the body. Hypervolemic hypernatremia occurs when there is too much sodium in the bloodstream. An actual loss of sodium from the body may occur from the gastrointestinal system through vomiting, diarrhea, nasogastric suctioning, tap water enemas administration, and GI surgery. A sodium loss can occur through the integumentary system through diaphoresis, severe burns, and wound drainage or suctioning. Sodium loss may also occur through the renal system by diuresis. An endocrine system loss of sodium may be caused by decreased aldosterone secretions by the adrenal glands. Medications which act directly on the kidneys to increase urine production may also be attributed to sodium losses from the body. Inadequate intake of sodium is yet another cause. Intake of salt-free solutions, such as water, without adequate dietary sodium intake, or an eating disorder, such as anorexia, may lead to a sodium deficiency. Relative hyponatremia may be caused by water gain or third spacing, resulting in a relative dilutional decrease in sodium content in the body. Excessive intake of hypotonic fluids, as seen in excessive intake of salt-free solutions, such as water, or a psychogenic condition called polydipsia, which is excess water drinking in the absence of a physiological stimulus to drink, or the administration of hypotonic IV solutions. Adrenal insufficiency or adrenal failure may also be a cause of relative hyponatremia. Decreased aldosterone secretion from the adrenal glands causes an increase in water retention by the kidneys, resulting in greater dilution of sodium in the blood. Hyperglycemia increases the osmolarity or osmolality of the ECF, causing water to be pulled out of the cells and into the ECF, resulting in increased ECF volume. dilution of the serum electrolytes, and cellular dehydration. The syndrome of inappropriate antidiuretic hormone secretion, SIADH, is a condition in which the antidiuretic hormone is secreted by the hypothalamus in excessive amounts or at the wrong time. Too much ADH causes the body to retain water, diluting the concentration of sodium, which results in relative hyponatremia. Finally, third spacing, the accumulation of fluid in the body where fluid does not normally collect, results in a relative loss of sodium and may be caused by any condition associated with edema or ascites, such as heart failure or liver failure. Actual hypernatremia may be caused by sodium gain or sodium retention, resulting in an actual increase in sodium content in the body. Sodium gain may be caused by the excessive intake of sodium via oral and IV routes. Excessive oral sodium intake can occur through the diet or near drowning in salt water. Concentrated parenteral and enteral feedings that are not properly diluted can cause hypernatremia, dehydration, and other electrolyte imbalances. Hyperaldosteronism is a condition in which too much aldosterone is produced by the adrenal glands. It causes water and sodium retention. Corticosteroids use can have side effects such as hypertension, hypokalemia, and hypernatremia. Acute kidney injury adversely affects the kidney's ability to filter and remove water and sodium, and therefore be an actual increase in sodium or hypernatremia. Relative hypernatremia may be caused by excessive water loss or inadequate water intake, resulting in a relative increase in sodium content of the body. Excessive water loss through vomiting, watery diarrhea, diuretic therapy, burns, perspiration, fever, or other forms of insensible loss may result in a relative increase in sodium. Osmotic diuresis is excessive urination that causes solutes in the blood, especially sodium, to become more concentrated as the water is excreted by the kidneys, increasing the blood's osmolarity. Finally, the inability to ingest water or decrease fluid intake may also result in a relative increase of sodium in the body, as seen when there is an inability to ingest water or a decreased fluid intake. Infants, young children, and older patients are at greater risk. The nurse should conduct a focused nursing assessment for sodium imbalance, beginning with a thorough nursing history. Interview the patient and family members to reveal any risk factors or pre-existing conditions that would contribute to sodium imbalance, such as vomiting, nasogastric suctioning, diarrhea, kidney injury, or other conditions associated with sodium loss or gain. The nurse should assess the patient's ability to drink and tolerate oral fluids and obtain a current dietary history, inquiring about sodium intake. The nursing history should also include lifestyle factors such as the consumption of beer, the use of illicit substances, and current medication use. A thorough physical assessment is necessary because sodium imbalance can affect many body systems. Assess each body system, observing for manifestations of sodium imbalance as well as associated fluid imbalance. Measure and record patients' vital signs and review the patient's laboratory data to assess for the presence of hypo or hypernatremia. Monitor for cardiovascular change. Auscultate the apical pulse rate. Observe for jugular vein distension. Palpate peripheral pulses. Check orthostatic blood pressure. Observe for peripheral edema. Monitor for cerebral changes. Establish the patient's usual cognitive and behavioral patterns. Observe the patient's behavior, level of consciousness, and mental status. Monitor for any seizure activity. Cerebral cells are highly sensitive to changes in sodium level and fluid volume. Brain cells swell in the presence of hyponatremia and shrink in the presence of hypernatremia, which when severe may lead to seizure activity, coma, or death. Monitor for gastrointestinal changes. Auscultate bowel sounds in all four quadrants. Observe frequency and consistency of bowel movements. Monitor for neuromuscular changes. Establish a baseline for the patient's deep tendon reflexes, muscle strength, and tone. Monitor the patient for muscle weakness, muscle twitching, or irregular muscle contractions during each nursing shift. Weigh the patient daily. Evaluate the patient's weight gain or loss over 1 to 3 days. Weigh the patient at the same time each day, preferably before breakfast, with the same amount of clothing on and using the same scale. An increase or decrease in body weight may indicate fluid gain or loss influenced by or causing a sodium imbalance. Measure intake and output at least every 8 hours. Record the type and amount of all fluids received and describe the route as oral, parenteral, rectal, or by enteric tube. Record ice chips as fluid at approximately 1/2 their volume. Compare the patient's intake with that of an average adult. Record the type and amount of all fluids the patient has lost and indicate the route. Describe output as urine, liquid stool, vomitus, tube drainage, and any fluid aspirated from a body cavity. Measure the amount of irrigation fluid instilled, subtracted from the total output when irrigating a nasogastric tube or the bladder. Monitor the patient and the patient's serum sodium level as ordered by the healthcare provider. Normal reference range for sodium is 135 to 145 milliequivalents per liter. Ensure patient safety by providing a quiet room, limiting the visitors, darkening patient's room, and speaking in soft tones. Implement seizure precautions related to neuromuscular irritability. Pad the side rails. Have oxygen and suction equipment available in the patient's room. Administer medications as prescribed by the healthcare provider. Ensure the patency of IV access devices. Implement fall precautions related to muscle weakness caused by hyponatremia and severe hypernatremia. Perform a fall risk assessment. Maintain the bed in a low position with lock wheels. Remove all obstacles from pathways, especially to the toilet. Monitor the environment for safety hazards. For example, torn carpet, liquid spills on the floor. Place assistive devices, walkers, canes, within the patient's reach. Use night lights. Instruct the patient to request assistance to ambulate. Ensure the availability of the call light is within reach. Assess footwear and provide appropriate footwear if necessary. Patients should be using anti-skid soles for ambulating. Keep items such as telephone, water, Kleenex within patient's reach. Request that the family members remain with the patient if necessary. Position the patient to allow for close observation by staff members. Finally, make sure to communicate the patient's fall risk during shift report and document not only your assessment, but also interventions taken to prevent a patient injury. For hyponatremia, increase oral sodium intake and restrict free water intake. For acute and chronic hyponatremia with severe manifestations, administer small volumes of IV hypertonic saline solution as ordered, only enough to increase the serum sodium level by 4 to 6 milliequivalents per liter over the first 1 to 2 hours. Monitor the cardiac rhythm of the patients receiving hypertonic IV saline solutions. Delay achieving a normal sodium level or hypernatremia for the first 48 hours. Treat hypovolemic hyponatremia with IV normal saline solution as ordered to restore both sodium and fluid volume. For hypernatremia, decrease oral sodium intake and ensure adequate water intake. Administer IV solutions, usually hypotonic, as ordered if fluid loss is the cause of the hypernatremia. Administer isotonic IV normal saline as ordered if both fluid and sodium losses have occurred. Categories of medication administered as ordered to treat hyponatremia include analgesics, antiemetics, antiepileptics, arginine vasopressin receptor antagonists, and corticosteroids. Analgesics are used to decrease pain related to headache. Usually acetaminophen, Tylenol, or another NSAID are used. To treat nausea and vomiting, antiemetics such as promethazine or ephedrine may be prescribed. To treat seizures that are a result of hyponatremia, antiepileptic drugs such as phenytoin or Dilantin are ordered. Arginine vasopressin receptor antagonists to increase free water excretion without sodium excretion are used only in euvolemic or hypervolemic hypernatremia. Examples of drugs in this category are conivaptan or Vaprisol and tolvaptan or Samsca. Corticosteroids are used to decrease cerebral edema. An example of a drug in this category is methylprednisolone or Solumedrol. Hypernatremia is treated with diuretics to promote sodium loss by increasing urine excretion. Either a loop diuretic such as furosemide, Lasix, or a thiazide diuretic such as hydrochlorothiazide, Diuryl, are ordered by the healthcare provider. Teach the patient or caregiver the causes of sodium deficit. Teach the patient how to prevent sodium deficiency by drinking water in moderation and ingesting drinks that contain electrolytes to replace fluid loss during exercise and hot weather. Include medication administration, nutrition, hydration, dietary restrictions, and foods high in sodium in patient teaching. Teach the hypernatremic patient or caregiver the causes of sodium excess. Teach the patient how to prevent sodium excess by avoiding high sodium foods. Instruct the patient on the specific definitions of reduced sodium food products. Low sodium is less than 140 milligrams per serving. Very low sodium is less than 35 milligrams per serving. Salt-free or sodium-free is less than 5 milligrams of sodium per serving. Recommend the seasoning of foods with either spices, herbs, lemon juice, or pepper. Instruct the patient to avoid medications that contain sodium, such as Alka-Seltzer or Bromo-Seltzer. Whether the patient is diagnosed with a sodium deficiency or a sodium excess, instruct both the patient and the family to notify the primary health care provider if the patient exhibits signs or symptoms of hyponatremia or hypernatremia. Listed on this slide are some examples of foods that are high in sodium. It is very important to include teaching the patient and family how to read food labels that list the amount of sodium contained in each serving and list other sodium-containing compounds such as MSG, baking soda, or sodium nitrate. Document all assessment findings and interventions per facility policy. Evaluate and document the patient's response to interventions and education. Serum sodium levels should return to normal range of 135 to 145 milliequivalents per liter. Other laboratory values should also return to normal ranges. Vital signs should return to patient's baseline. Underlying cause of the sodium imbalance should be resolved, and the patient's level of consciousness should return to baseline.